Hello, this is Dr. Neil Malden from the Western Veterinary Cancer Center located in Calgary, Alberta, Canada. What I'd like to talk about today is a subject that is near and dear to my heart, namely advances in radiation therapy. And really what I would like to do is talk about some of the treatments uh, that have become available to us on the veterinary side and some of the technological advances that have allowed us to greatly improve our ability to treat cancer patients, both from a treatment delivery to the tumor standpoint, but also from our ability to spare the normal tissues of patients, which is where most of the radiation toxicity that we see comes from. So I guess the first concept for us to cover is something called intensity modulated radiation therapy. And IMRT was quite a large advance from a radiation therapy perspective, and that it allowed us for the first time to really use a computer controlled multi-leaf collimator to dynamically shape a field. And what that means is that we're able now to really change the shape of the field while it's being delivered to a patient. And in so doing, as we change the shape of that field, we change the dose of radiation that's being delivered to different parts of the field. And that's called fluence. So the amount of radiation being delivered to any part of a radiation field is the fluence or the radiation dose. And our ability to change the fluence within a field is what allows us to concentrate the radiation in the tumor while minimizing radiation to critical normal structures. And as I mentioned, for conventionally fractionated protocols, I guess old school protocols, the dose of radiation that was delivered to normal tissues is where the vast majority of the toxicity comes from. So our ability to decrease dose to normal tissue should also decrease the radiation toxicity that we have to deal with. So this is a static image of a dynamic MLC. So this is looking up the treatment head. So radiation would come out of this port and shoot at us if the machine was on. And you can see that there's all these leaves that are making up this relatively complex shape. And each one of those leaves can move independently. And more importantly, each one of those leaves can move while radiation is being delivered. And that's again where the concept of fluence comes in. As this collimator changes shape, it's going to change the dose of radiation being given to any particular part of the treatment field. I'll apologize in advance for this video. It's going to be a little bit on the shaky side. It was taken in a very dark vault without a tripod. This is that same shape we were just looking at. The light is a light source that allows us to see positioning in the dark, but it could just as easily be high energy radiation that we were seeing if we were using this from a treatment perspective. And as we engage the linear accelerator, we'll see that the leaves start to move. And if this was a patient, then as those leaves moved, they're blocking areas of radiation within the treatment volume. So anywhere that there's light means that there's radiation that would be being administered, and anywhere that it's dark is areas that are effectively being blocked from radiation so that none is being delivered. This is, I guess, an example of fluence using Albert Einstein as our prop. So this is obviously an image of Einstein, and it looks a little grainy and pixelated. And the reason for that is this is actually an image that is taken with a dynamic multi-leaf collimator. So the way it was achieved is an image of Einstein was scanned in as a grayscale, and then that grayscale image is essentially the same as a fluence map. So areas that are darker would be areas that the linear accelerator would interpret as needing more radiation. Areas that are lighter are areas that it should be blocking radiation and there should be less exposure. And then when we ask the linear accelerator to recreate that fluence map on a piece of film, this is the image that we get. This is not something that we did here at Western Veterinary Cancer Center. This was done actually a fair number of years ago, and actually the I guess the resolving power of the collimators have gotten much better since the days that this image was made. So that sort of leads us, that concept of being able to modulate the intensity of a radiation beam and to change the fluence leads us then to a fairly simple question. What would happen if we could combine the precision of an IMRT treatment, so the ability to change the dose being delivered to each part of a radiation field with advanced positioning and immobilization, allowing for the delivery of a large dose of radiation to a very repeatable target with a millimeter or submillimeter accuracy. And as I say, it's a fairly simple question. It just ends up having a fairly complicated answer. So this graphic is a little bit busy, but really what it is showing is the workflow that has to happen to get a patient treated with radiation. A lot of times they say, okay, well, let's just get that patient treated, let's give him a dose of radiation. Sounds fairly simple, but the steps we have to go through to make that process happen are actually fairly complicated. So we'll start up here. And this is a patient that's getting ready to have a CAT scan performed. And really that image information is critical to everything else. We're going to take that CAT scan data, we're going to build a little three-dimensional patient, and then based on that, we're going to use that to help us target the radiation dose. So CAT scans performed first. That data is sent to a treatment planning computer. Our platform is called Eclipse. There's other ones out there that can do exactly the same thing. And then Eclipse sends that information to the LINAC control. So we create a plan in Eclipse, it gets sent to LINAC control, and then images from that plan are sent to the linear accelerator. We'll compare images between the patient and the computer-generated images to see if they match. That process is called portal imaging. So those images are sent to something called Portal Vision, and then that in turn sends it to a record and verify system. We use one called TheraView. There are lots of different ones. And what happens in this step is we compare our actual patient image with the predicted image and see if they match up. If they do, then LINAC control is notified that everything looks okay. Then we go to a step where we actually verify the fluence. We can use something called a phantom, which allows us to verify the dose being delivered in real time, and we can look at the fluence map between the predicted fluence from the plan and the actual fluence being delivered to the patient. If those numbers agree, then we go beam on, and now here we are with the linear accelerator actually treating a patient. If either the portal images don't agree or if the fluence map doesn't agree, then we get kicked back to an earlier stage in the workflow because we can't treat those patients until we're positive that the dose we're delivering, or the dose that we think we're delivering, is actually the dose being delivered, and we have to be sure that the positioning is right before we start to treat a patient with radiation therapy. So that leads us then to the concept of stereotactic radiation therapy, which is a newer treatment option for veterinary cancer patients. It's been around in the human world for quite a while. The main reason that we've been so delayed in evaluating it on the veterinary side is the fact that the technology is quite expensive, and it's just now reaching a point where it's even economically feasible for a veterinary practice to think about getting into these kinds of therapies. So there's lots of different terminology out there for stereotactic radiation therapy. You'll see terms like SRT, which is what we'll use here. There's SBRT, stereotactic body radiation therapy. There's stereotactic radiosurgery, which purists would say only applies to the brain and only applies to single fraction therapy. So a little bit of confusion on the terminology side of the fence, but they all essentially mean the same thing. They are radiation programs designed to immobilize a patient to achieve a high degree of reproducibility and positioning, and then to deliver radiation dose in a compressed time frame. So most of the stereotactic protocols used in veterinary medicine deliver a curative intent dose of radiation in 3 treatments given either on consecutive days or on an every other day basis. And really what that means from a logistical standpoint is that patients with radioresponsive tumors can now be treated in a week or less compared to the 4 to 7 weeks typically required with conventionally fractionated protocols. So when we think about stereotactic RT, the very first thing that we have to achieve is 3D planning, and you can't do stereotactic without 3D planning systems. So we need an accurate, precise, and highly reproducible positioning, and then we need complex 3D planning so that we can identify the actual structures that we wish to deliver radiation to, such as the tumor volume, but also structures that we want to avoid. Say if we're treating a patient with a head and neck cancer, then we want to make every effort to try to avoid the eyes and the lens of the eyes and maybe the brain. So again, that's the biggest part, is building your model where you get an accurate 3D representation not only of the patient, but of the structures within the patient, both that you want to treat and that you want to avoid. Radiation therapy planning's come a long way. This is a radiation therapy planning computer from when I was finishing my residency. So we had our trusty little Hewlett-Packard calculator, a couple of different kinds of rulers to measure distances and thicknesses, and then a scratch paper that we could do the calculations on. So again, the idea of being able to do really significant or sophisticated 3D modeling just wasn't possible then. And really the changes come about because of the change in desktop computing power. We have desktops now that can do things that we couldn't do with an entire room full of servers back in the late 1980s. So the mantra of stereotactic radiation therapy is precision and reproducibility. We have to be able to lock a patient into place and to be sure that we can get that patient reproducibly positioned, and so that the position they're in for the CAT scan and the position they're in for treatment 1 and treatment 2 and treatment 3 are exactly the same, or as close to exactly the same as is humanly possible. We use an immobilizer that's what's called a frameless immobilizer, and what that means is we're kind of building this clamshell case that is specific to the patient. And that immobilization device consists of two parts. The first is a thermoreactive foam that we use to create a rigid cast of the treatment area. This foam consists of two components that you mix together and shake up, and then they expand to about 800 times their original volume over 45 seconds to a minute, and then they harden over a few minutes into a fairly rigid structure. And then we can kind of shape that structure however we want to around the patient. And then the second part of the device consists of a thermoplastic mesh that's flexible when it's heated. It can stretch it over the top of the patient, conform it to all of the anatomy, and then again when that cools down, you have a rigid clamshell top that really locks your patient into place fairly securely. So this is a patient with a kind of cancer called a carcinoma located at the base of the skull, not a surgical patient. So he was one of the first patients that we treated with a stereotactic radiation protocol. So he's in position to have the bottom part of his mold made. This black aluminum frame is really just to kind of help control the expansion of the foam and help it conform around the head and neck so that we can get a good mold of this particular patient. Again, two separate compounds that you mix together. The instructions are to shake vigorously for 20 seconds. We learned the hard way that you need to stick to that 20 seconds early on in our stereotactic learning curve. Well, we got distracted while we were making up one of the bottles of foam, set it down to answer the phone, and that was followed by an pretty loud explosion a little later, and then many months of us scraping hardened foam off of pretty much every structure in the LINAC vault. So planning and timing is fairly essential when you start making up the bottom part of the immobilizer. This little video kind of shows you the reaction. Once it gets going, it is a fairly exuberant reaction. There is some heat generated here, so you have to be careful with your patients. We've actually worked with the company to sort of redesign the foam so that it's kinder for veterinary patients. I'm not going to show this to conclusion, but by the time that's done, we would essentially fill up that entire box with the foam, and then that would form the bottom part of our immobilizer. So here's that same patient we had looked at earlier. He's in the immobilizer now. You can see it's kind of expanded up around his head. So now the next step is going to be to kind of shave that away and to carefully shape it so that we get good control of the bottom part of the anatomy that's going to be irradiated, but where we can still see the top part of the patient and to get the clamshell molded as well. Here we are molding the thermoplastic mesh, and you can see that it sort of folds over, and then as we conform it to the patient, it actually will conform pretty closely, and then as it cools down, it becomes rigid and it maintains that shape. And this white frame is actually part of this mesh, and it's an indexing frame. It locks into the table at specific positions. And the table has index marks on it so that we know if we lock this in to index mark B today, and then we do that again tomorrow, that we should have that patient in exactly the same position or very, very close to that. And now here's our patient ready to go to CAT scan. There are lasers in the radiation vault and lasers in CAT scan. These are aligned similarly so that they identify a sort of virtual point in space, something that's called isocenter. And isocenter is sort of the point in space that the linear accelerator is going to rotate around. So we define that point down the linear accelerator vault, we confirm that point up in the CAT scan, and then hopefully between those two, using the laser alignment, the position our patient is down in the vault will be exactly the same position that he's in up in CAT scan. So this is a different patient now, but one getting ready to have their therapy planning CT. You can see the mesh. This is actually a newer form of mesh than what was seen in that previous patient. And we have these little BBs are called fiducials. And the only reason they're there is so that I can see them on the treatment planning computer, because the intersection of those 3 points tells me exactly where isocenter is and lets me work from there when I'm creating the radiation therapy plan. And then here's that same patient ready to go into the CT gantry. We can't make this room quite as dark as the vault, but you can see the lasers here aligning to those fiducials, just like would have happened down in the linear accelerator vault. So another concept we need to quickly cover from a radiation therapy perspective is something called the dose volume histogram. And what that is the DVH is a comparison of the volume of a structure being irradiated to the dose that's being given. So here's 0% volume up to 100%, and then here's 0 dose out to whatever percent it might end up being. And ideally what we would like to see is all of our normal structures, all these colored lines here, we'd like to see them have 0 dose. We know that's not possible because we have to go through normal tissue to get to our tumor, but that would be the ideal. And from a tumor perspective, we would like to start out at 100% of the tumor volume, come out to 100% of the dose. In this case, that would be about 2400 gray, and then centigrade. And I'd like to see a knife edge drop down to 0 volumes. Again, the physics in the real world are never quite that good, so that there's usually less than perfect configuration of these, both from a tumor's treatment standpoint, but also from a normal tissue standpoint. So the way we achieve the best dose volume histogram possible is really in the creation of the plan. And the plan itself is a fairly complex, I guess getting a plan is a fairly complex process, but there's 2 basic steps to it. Step number 1 is to do something called beam angle optimization. And what we're going to do there is we're going to find the best beam configuration. And the way we do that is by first creating a tumor, first creating a volume of our patient. And then you can see here, this is a kitty cat with a head and neck tumor. This red volume is the cancer, so quite a large volume of tumor. This is a tumor type called melanoma. And then we can actually add in our normal volumes as well. So I've contoured the left and right eye, and I've also contoured the left and right lens. And that those structures are critical, and we'd like to save them if we could. You can see that the right eye is outside the tumor, although fairly close, but the left eye here is pretty much completely surrounded by this red tumor volume. So that's going to be a little bit problematic for us going forward. But once we've got our patient contours all defined, then the next step is that beam angle optimization. And what happens here is the planning computer looks at the patient, looks at the volumes, and then I try to tell it what I want it to achieve. I try to tell it how much radiation dose I want the target volumes to get. I try to tell it how little dose I want the normal tissues to get. And then the planning computer tries to come up with the best solution that it can. With older treatment planning systems, it would usually take 45 minutes to an hour to go through one iteration of a plan, and then if that plan was okay, you used it. If it wasn't, you might change it and have to go through another 1 or 2 hours of calculations before you got the result. So what would tend to happen is you would do 1, 2, maybe 3 different versions of a plan, and then you would say, okay, that's as close as I'm going to get. I have to move on to the next patient, so this is the plan I'm going to use. With the newer computing power that we have in these planning platforms, we can actually look at hundreds of thousands, hundreds of millions of possibilities, and that's really what's happening now. The computer is looking for the best angle combination of beams that it can find to allow me to treat the tumor to the specifications that I requested, and to spare the normal tissue, also trying to meet the specifications that I requested. What we're seeing, you're seeing sort of a real-time dose volume histogram here. The computer's showing us what it can do with these red lines, which are the tumor volumes, and then these guys are the different structures, the left and right eye and the left and right lens that I've asked it to try and salvage. Right now the plan has come up with 7 beams that it thinks are optimal, and it's just fine-tuning the angles of those beams, and once it's happy that it's done the best it can, it's going to tell me that optimization is finished. And so once we've got the beam angles defined, the next thing we have to do is define the fluence, and we do that with the multi-leaf collimator. So again, another optimization step. We've got the 7 fields that were defined in the previous step, and now we're asking the computer to look at all the different possibilities of collimator shapes in order to give me the ideal fluence for each one of these fields, so that when we add them all together, when we actually deliver the dose of radiation to the patient, we get the best possible combination of tumor dose and normal tissue dose possible. So what we're seeing here, this is sort of a real-time fluence map, and you can kind of see this cold spot. Radiation dose plots are sort of like weather maps. The bluer you are, the colder you are, and then if you get down to having a black background, that means there's no dose being delivered in that area. So you can see as it's working again, sort of a real-time dose volume histogram. I moved these down. I wanted it to try to save my right eye a little bit better than what it was doing before. But you can see we've got this sort of bluish area here. And what that is that left eye. That's the computer doing its best to save the left eye to the degree that I asked it to. And I can change the rules from a planning standpoint. I can tell it how much or how little I want it to try to meet one of my criteria. And as it meets those criteria, again, you'll see the DVH kind of constantly change. And then the operator's job, or my job, is to say, okay, this is finally as good as it's going to get. But again, probably the greatest strength of these platforms is that now instead of 1 or 2 plans and then say, okay, that's close enough, now thousands or hundreds of thousands of plans are being evaluated. And you can see as we move down through the different fields, each one of them was sparing the left eye to the best of its ability. So this is what I see after those 2 steps are done. So now this is showing me one of the treatment fields, one of the 7, and you can see this sort of irregular yellow shape. That is the static outline of the field to be treated. And then each one of these blue bars represents one leaf of the multi-leaf collimator. And you can see as we kind of run through this animation, it is going to actually show me the position that each leaf of the multi-leaf collimator is going to take as it treats the patient. You'll see that it skates over the eye pretty quickly, so it's really trying to block the left eye as best it can. And then when it gets to the red part, the tumor part, you'll see it sort of slow down a little bit and deliver more radiation. And so this particular field had 75 different shapes to it. And when I counted up all the shapes for each beam for this particular patient, it was 720. So as opposed to a conventional protocol where we might have 2 fields with only 2 shapes, this patient's actually being treated with 720 individual field shapes, trying to maximize dose to tumor and minimize dose to normal tissue. So let's sort of look at the finished product and see what that looks like. So here's our patient contour again. And we can, just like with the pre-planning, we can turn on all of the different internal contours as well, so we can see what the anatomy looks like. And then if we turn on the actual beam angles, you can see that it's a fairly complicated treatment geometry. So this is now that patient sort of showing us virtually what all 7 of the treatment fields look like as we're trying to push dose into her tumor. This is the dose volume histogram for that patient. Not quite as good as the one we had looked at earlier, but I think pretty acceptable based on what we asked the planning computer to do. So these red lines again are the target volumes, and we've got a little bit more of a tail than we would perhaps like to see, but it's a very small percentage of the tumor, less than 1 or 2%, that's actually getting that tail. The left eye are these 2 green lines here. We knew that we weren't going to be able to spare that eye very well, so there's a higher volume, getting a higher dose for the left eye. The right eye is actually pretty nicely spared, considering how close it was to the tumor volume. So this is our actual patient, and you can see the large swelling here, and then this tumor extends quite far back behind this photo. She's anesthetized now, which is why she's looking a little bit out of it. But this is her pre-treatment, so she has had no radiation now. This is her 72 hours after treatment number 3. Still got a little bit of nasal discharge, but we're already starting to see some resolution in the size of her tumor. And oral melanoma in cats is a fairly uncommon disease. It's quite common in the dog, but it is a tumor that tends to have an aggressive course of action. And with the volume of disease that this kitty had, I thought that we were probably shooting for palliation and hopefully buying her a month or 2. Here she is 16 months post-therapy, and there's a couple of striking things about this photo. One is the fact that you can see the hair coat change from her radiation field. That is a fairly common thing to see, and with the stereotactic protocols, usually we're going to see some pretty significant hair coat color change within the irradiated fields. But the other thing that's fairly striking is she does have a little bit of cloudiness to her eyes, but she certainly doesn't have mature cataracts, even here in the left eye, which is the eye that got the high dose of radiation, or the higher dose of radiation in her treatment plan. So I think all in all, this is a fairly successful patient from the standpoint that we bought her a good amount of survival time, that we controlled her tumor, and that we managed to do that without causing a lot of normal tissue toxicity. So this is sort of a static image, and again, this is all the radiation dose that we're seeing here. And the brighter the bluer the zone, the colder it is. And so these red lines are showing us the tumor outline, and you can see that tumor is all pretty much within this red hot zone of radiation. But really the interesting thing, and from a radiation therapy perspective, the holy grail-ish kind of thing, is look at how the dose is bending around the eyes. This is the patient we looked at the very first, the one that I showed you the immobilizer being made for, and you can see how nicely the fields were able to be bent around the eyes, and that we really got good tumor dose with fairly minimal dose to the globes themselves. Then the next step, as I said, we need to be sure that the positioning that we think we've achieved and the positioning we've actually achieved are the same. We do that by a portal comparison. So this image, the image on the right, is not really an X-ray. This is something called a digitally reconstructed radiograph, a DRR, and this is the treatment planning computer's prediction of what an X-ray taken through this treatment head would look like. This is the actual X-ray. This is called a port film. Port films are generally lower quality radiographs because of the energy being used to make the X-ray. Newer machines can do a much better job getting diagnostic quality X-rays, but the port films, even from a megavoltage machine, are still pretty good. And then what you do is you outline the different anatomy between the two, the bony anatomy that you can see between the two, and then the computer will overlay those and tell us how close we are. And for this particular image, we're right on from a vertical translation, and we're right on from a rotational translation, and it's telling us that we need a shift horizontally of 0.6 millimeters. 0.6 millimeters is about 2/100ths of an inch, which is about the equivalent of 2 pixels on your monitor if you've got your monitor set to 100 dpi. Our action level for a patient is 2 millimeters. So if we have a shift outside of the 2 millimeter range, then that patient needs to have a shift done and have port films then redone and confirmed prior to radiation being delivered. One other clinical case to show you, this is a dog, and this is a dog with a tumor type called tonsillar squamous cell carcinoma, which tends to be a particularly aggressive form of cancer in the dog. So again, here we are, normal tissues, the eyes and the lenses are both defined. This mass here is the tonsil, and then it's sort of confluent with a much larger mass, which is lymph nodes. And the survival time for tonsillar squamous cell carcinoma treated with an old school conventional protocol is typically somewhere in the 6 to 8 week range. We really used to think of radiation as being a palliative course of action for those patients. Here's just a look at its setup, again with the different fields all around. So this is the pre-treatment CAT scan in this guy, and we're sitting right at the level of the second cervical vertebra, so we're right just a little bit behind his skull, behind the base of his skull, and all of this contrast enhancing mass here is tumor. So fairly large tumor volume on the right side, compressing. The larynx is here. Normally you would expect it to be right on the midline. It's getting pushed over as well. This is a post-therapy CT done about 3 months after completion of therapy, and we've had almost a complete response of the tumor. You know, there's still maybe a little patchy contrast enhancement here, but certainly nothing like what we had in the pre-treatment scan. This contrast enhancing structure here is a normal structure. This is the salivary gland. It's a little bit smaller and more irregular than the left because it did get damaged some by the radiation, but all in all we had a very good response to radiation therapy. This patient lived almost 16 months, and then when we lost him, we did not lose him because of regrowth of the primary tumor. He developed systemic metastasis with tumor spread to his lungs, which was the ultimate cause of his death. So to finish up, I guess let's talk about the pros and cons of stereotactic radiation therapy. The advantages, it allows rapid delivery of a curative intent dose of radiation, so fewer treatments over fewer days. From a practical standpoint, probably the most important part of that is that there are fewer anesthetic events. Obviously, veterinary patients have to be anesthetized for each radiation treatment. So a stereotactic protocol requires 4 to 5 daily anesthesias compared to the 16 to 21 that would be required for a conventional protocol. The acute toxicity is generally much less than what we see with conventional protocols, and they do actually tend to be cost effective compared to conventionally fractionated protocols. Even though each dose of radiation is much more expensive, there are fewer of them, and there's fewer anesthesias, and the anesthetic costs are a significant portion of what makes up the expense of a radiation therapy protocol. And then probably from a family standpoint, the biggest benefit is that patients can be treated in a week versus the 4 to 7 weeks necessary for conventional protocols. This is particularly important in a country like Canada, where we have a very large land mass with a fairly small population density, and a lot of my patients are coming from very far away. So if you live in the Yukon, I might get you down here for a week if I can get the radiation done in that short a period of time. But if it's going to take 4 to 7 weeks, then that patient probably will never present for any radiation therapy. So from a population standpoint, it is a much better way to go because it allows me to turn these patients around much more quickly than I can with a conventionally fractionated protocol. The disadvantages are that even though there are fewer anesthetic events, they may be longer anesthetic events, and that's due primarily because that the accuracy of positioning has to be spot on, and that a lot of extra effort sometimes goes into getting those patients in the appropriate position. I'd say the learning curve on positioning is fairly steep for stereotactic protocols, and we found our treatment times going down, down, down over the years that we've been working on these patients. But still, I would say that the typical anesthetic time is going to be longer for a stereotactic protocol than it will be for a conventional protocol. Not an instant gratification therapy. Even though the radiation is delivered over just a 3-day period of time, the biologic effect of the radiation keeps working for months and months after the radiation delivery is complete. So for some tumors, we don't start to see good tumor resolution until 2 months, 3 months, 4 months in, and it may be 6 or 9 months before we get the maximum benefit of radiation in that individual patient. I do see some families that want stereotactic RT purely for the logistical convenience. And usually those are patients that have had surgery and now have no residual disease, and then they present here for a stereotactic protocol. And one of the rules for the stereotactic delivery of radiation is there has to be a target. I have to be able to identify what the tumor is so I can separate tumor from normal tissue. So in a post-operative patient who's had their tumor taken down to microscopic disease, there's no target there, and the only way to effectively and safely treat those patients is going to be with a conventionally fractionated protocol. Probably the biggest disadvantage to SRT is it requires very complex field geometries to deliver and very sophisticated technology to deliver effectively and, more importantly, safety. And then probably the final point is we're still in the early days from a veterinary perspective for this technology. So it's difficult for us to compare, say, 5-year control rates for a specific tumor treated with conventional radiation compared to patients treated with the same tumor treated with a stereotactic protocol. We're one of the earlier adopters for using stereotactic radiation, and we're just now coming up on 4 years of using the technology. There are other centers out there that have been doing it longer than us, but still we don't have long-term data yet, so it's hard to compare apples to apples when we're trying to look at control rates between a conventionally fractionated and stereotactic protocol. When we think about tumors, I kind of put in a little quick reference guide here. Head and neck, extremity, and pelvic canal are probably the biggest tumor types that we treat. Lots of head and neck cancers because we get to the point where complete surgical removal is not possible, or that the kind of reconstruction we would have to do to get the tumor removed completely surgically is not something that the family thinks is a reasonable course of action. Same is true for extremity tumors. I see lots of patients where the simple oncologic answer is probably amputation, but they elect to proceed with a stereotactic protocol in an attempt to salvage the limb, if at all possible. So when we think about appropriate SRT targets, probably the first thing to do is to rule out the ones that are not appropriate, and any area of the body that's going to have a high degree of motion is not really an appropriate candidate for SRT. For us, practically, what that means is the chest wall. If you have a large breed dog or a person with a tumor on the chest wall, well, that tumor is moving quite a bit every time a breath is taken. So if you're targeting a tumor with a 1 to 2 millimeter margin and the respiratory effort moves the tumor a centimeter each way, then you're not effectively delivering radiation in that patient. So if there's a lot of motion, we probably can't do a stereotactic protocol. We need to go back and look at our conventional alternatives. Uh, any tumor where local control is the primary objective, and where you would say, okay, I want to cut that off, but I can't, then I think stereotactic is at least a reasonable consideration in those patients. We have to be able to adequately position and immobilize them, but if we can achieve that, then I think that we should at least entertain the concept of SRT for that individual patient. So with that, I'll end the show. I apologize for the length, but you should never let a radiation therapist talk about radiation therapy. I'm happy to entertain any questions you might have. You can reach us at the blog, www.vetoncology.org, or via email, vetoncology@vetoncology.org. Again, thanks for watching, and stay safe until next time.